Hello, everybody. Today's topic of discussion is asthma management in ICU. So, asthma is the chronic inflammatory disease of airways characterized by the variable airway obstruction. Inflammation causes airway obstruction by making the smooth muscle more sensitive to contractile stimuli, by thickening the air wall with edema and inflammatory cell infiltration, and by stimulating gland to secrete mucus, and by damaging the epithelium, and by remodeling the architecture of the airways. Acute exacerbation of asthma may punctuate the course of mild, moderate, and severe cases of chronic asthma. These exacerbation and the flare of asthma can be life-threatening and most commonly characterized by acute progressive worsening of respiratory symptom and pulmonary function that is severe enough to warrant a change in the treatment. These exacerbations are triggered by the poor adherence to the asthma controller medication or by exposure to environmental factors such as inhaled allergen, irritant, or viral infection of the respiratory tract. Assessment, management, and the prevention of exacerbation of asthma, especially those leading to respiratory failure, are the critical challenges of caring for patients with asthma. Regarding pathology, the bronchial biopsy specimen from patient with the asthma are pathologically abnormal with collagen deposition beneath the epithelial basement membrane, mucosal infiltration by eosinophils and neutrophil, mast cell degranulation, and epithelial damage. These findings occur in both severe and mild asthma, suggesting that airway inflammation is of primary importance in the pathogenesis of asthma. For exacerbation of asthma, the pathology of airway is variable, reflecting at least two recognized clinical subtype of exacerbation, that is slow onset and rapid onset. Slow onset exacerbation are most common and the patient represents more than 2 to 6 hours of symptom, often days or weeks of symptom. This suggests that most such patients should have sufficient time to seek medical attention for worsening shortness of breath. Microscopically, there is eosinophilic bronchitis with pronounced areas of mucosal edema and disformation of epithelium. Typically, hypertrophy and hyperplasia of smooth muscles are present and these muscles appear contracted. Patients with the rapid onset exacerbation present with the severe symptoms that have rapidly progressed over 2 to 6 hours. These rapid onset exacerbation may represent 8% to 14% of asthma exacerbation in general and can be fatal, leading to death in only a few hours after symptom onset. Pathologically, airway obstruction by mucus is not prominent and there is neutrophilic rather than eosinophilic predominance of inflammatory cell in airway submucosa. There is no specific clinical characteristic that reliably predict which patients are prone to this rapid onset asthma exacerbation. However, patients with rapid onset asthma exacerbation may more commonly report sensitivity to non-steroidal anti-inflammatory drugs. Regarding pathogenesis, asthma is a disease or group of disease with complex underlying genetics. So, why airway inflammation develops in asthmatic patient is not understood entirely, but much evidence suggests an important role of T helper immune responses. As a triggers of asthma exacerbation, inhaled allergen, pollutants, smoke, viral infection are all capable of worsening inflammation as already inflamed asthmatic airway. Up to 80% of asthma exacerbation are felt to be caused by respiratory tract infection in general, and it is likely that human rhinovirus accounts for the majority. When these environmental trigger interact with the asthmatic airway, inflammation is intensified and many release the mediators that have potent effect on smooth muscle function, epithelium and microvascular integrity, neural function and mucus gland secretion. All these factors contribute to narrowing of asthmatic airway with smooth muscle contraction, mucus secretion, epithelial cells sloughing, edema and inflammatory cell infiltration of the airway. This resulting the acute increase of airway obstruction, and it is the most commonly referred as acute exacerbation of asthma. Physiology, the major physiological consequences of increased airway obstruction during acute exacerbation of asthma are hypoxemia and increased work of breathing. Hypoxemia occurs by at least two mechanisms. First, airway obstruction increases the resistance to airflow in conducting airways, and this results in uneven distribution of ventilation to the alveoli. So, the hypoxic vasoconstriction of the vessel that supply the underventilated alveoli primarily compensate for this uneven ventilation, but overall ventilation perfusion ratio remains abnormal and the principal cause of hypoxemia during asthma exacerbation. Consequently, even patients with the severe exacerbation of asthma usually respond favorably to supplemental oxygen. Second, less common cause of hypoxemia among the asthmatic is right to left shunt due to atelectasis of lung distal to airway that are completely occluded by mucus or due to interarterial shunt precipitated by increased right atrial pressure from asthma-related increase of pulmonary vascular resistance. A second consequences of severe acute obstruction is increased work of breathing. During acute exacerbation, respiratory muscle must expend increased energy, generating large changes of pleural pressure to overcome high airway resistance. The resulting discordance between respiratory effort and change in the thoracic volume may play some role in patient sensation of dyspnea and central drive to increase minute ventilation. The ensuing rapid respiration further increase the work of breathing and worsen airway trapping behind the narrowed airway that prematurely close during expiration. This dynamic hyperinflammation of the lung with airway trapping increases respiratory muscle energy cost because it restricts the vital capacity to high thoracic volume where alveolar dead space is increased and the respiratory muscles are at suboptimal mechanical advantage and the lung is less compressed. All of these factors contribute to the significant increase in work of breathing, costing muscle more energy to achieve the same alveolar ventilation. Initially, the respiratory muscles may be able to exert the force needed to maintain alveolar ventilation, but muscles may fatigue if airway resistance increase rapidly and if and it's sustained and when there is inadequate oxygen delivery to these muscles. So dynamic hyperinflation due to severe airway obstruction also may impair cardiac performance by increasing right ventricular afterload and by decreasing venous return to the left atrium and by causing diastolic dysfunction. So regarding differential diagnosis, upper airway obstruction, that is extrathoracic, is anaphylaxis, arytenoid dysfunction, bilateral vocal cord paralysis, laryngeal edema, laryngostenosis, laryngoscene, mobile subglottic soft tissue, neoplasms, post-extubation granuloma, post-nasal drip syndrome, relapsing polychondritis, retropharyngeal abscess, supraglottitis, vocal cord dysfunction syndrome, and granulomatosis with polyangiitis. Then, regarding intrathoracic, acute tracheomalacia, airway neoplasm, foreign body aspiration, goiter, herpetic tracheobronchitis, right side aortic arch, tracheal stenosis due to intubation, and tracheobronchomegaly. Lower airway obstruction is due to because of aspiration, asthma COPD overlap syndrome, bronchiectasis, bronchiolitis, carcinoid syndrome, chronic obstructive pulmonary disease, cystic fibrosis, lymphangitic carcinomatosis, pulmonary edema, parasitic infection, and pulmonary embolism. Now, regarding assessment, history. The most frequent trigger for acute asthma exacerbation is respiratory viral infection. Additionally, allergen exposure, lack of controller inhaler use, and poor baseline asthma control, non-viral respiratory infection are common triggers that can be elicited in the history. Patient also should be assessed for the factor that increases in hospital mortality when obtaining history. Baseline pulmonary function tests that show persistent decrease in expired volume of air in 1 second, loss of lung elastic recoil, and hyperinflation at total lung capacity are associated with increased risk of near fatal asthma. A recent history of poorly controlled asthma, that is, increase of dyspnea, wheezing, frequent nocturnal awakening due to shortness of breath, increased use of beta adrenergic rescue medication, increased diurnal variability of the peak expiratory flow, recent hospitalization, and emergency department visit. Any history of prior near fatal asthma exacerbation, that is, prior admission to intensive care unit or intubation for asthma, are most important predictor for patients' propensity for severe life-threatening asthma exacerbation. Current or recent use of oral corticosteroid, not using inhaled corticosteroid, a history of psychological problem, poor adherence to asthma medication, cigarette smoking, history of food allergy, and are other warning that patient is at risk of asthma related death. When assessing risk for the fatal asthma, the other important historical detail include identification of current medication, coexisting illness such as psychiatric disease that interfere with the medical follow-up and cardiopulmonary disease. A history of known coronary artery disease is important because patient may be more sensitive to stimulatory effect of beta-2 adrenergic agonist and to cardiac complication of hypoxia. This patient may also be receiving beta-2 adrenergic antagonists that are making control of their asthma worse. In general, patients are somewhat better judges of the severity of their airway obstruction during the attack of asthma than are physicians who elicit the history at bedside. Patients complain of severe breathing difficulty, chest tightness, difficulty walking more than 100 feet, may suggest severe airway obstruction. However, patients' own assessment of airway obstruction should never be exclusive means of assessing severity of airway obstruction. Notably, patients with history of severe asthma sometimes have blunted perception of dyspnea. Regarding physical examination is important for excluding other cause of dyspnea and assessing degree of airway obstruction with primary goal of determining whether or not the patient need emergency intervention. Tachycardia, that is heart rate of more than 120 beats per minute, tachypnea greater than 30 breaths per minute, diaphoresis, upright posture in bed, pulses paradoxes greater than 10 mmHg, accessory respiratory muscle use, all should be regarded as sign of severe airway obstruction. However, because the absence of these signs doesn't rule out severe obstruction, physical examination cannot be relied on exclusively to estimate severity of airway obstruction. The amount of wheezing heard on auscultation of the chest is notoriously poor method of assessing severity of airway obstruction. Cyanosis is late and insensitive finding of severe hypoxia. Abnormal thoracoabdominal motion and depressed mental status due to hypoxemia and hypercapnia are ominous indicators and can herald the necessity for emergent mechanical ventilation. Regarding pulmonary function test to evaluate a patient who is having acute exacerbation of asthma, an objective measure of maximal expiratory airflow should be performed. An exception to this is the patient who is unable to perform testing maneuver due to severe life-threatening exacerbation with obvious airway compromise and cyanosis. Peak expiratory airflow rate and FEV1 are equally acceptable bedside measure to quantify the degree of airway obstruction. These tests are valuable for initial assessment and for assessing response to therapy, especially after 1 hour of treatment. In general, pre-treatment PEFR and FEV1 of less than 50% of baseline indicates severe exacerbation of asthma. Guidelines recommended reassessment of pulmonary function 1 hour after initiation of treatment and then frequent reassessment thereafter. Now, regarding objective assessment of airway obstruction after initial intensive therapy. So, the post-treatment peak expiratory flow rate is if it is less than 70%, then it is a good response, no need of hospitalization. If it is more than 40% and less than 69%, then incomplete response. We can consider the risk factor and If it is less than 40%, then poor response and hospitalization is recommended. Regarding ABG, analysis of ABG has no role in assessing and managing asthma exacerbation. It should be performed for suspected hypoventilation, severe respiratory distress, or when spirometric test results are less than 25% of expected. Also, any patient who fails to respond to first 30 to 60 minutes of intensive bronchodilator therapy should have ABG analysis to perform. Although ABG values are not predictive of overall patient outcome, there is some correlation between hypoxemia and hypercapnia and degree of airway obstruction measured by FEV. A partial pressure of arterial O2 less than 60 mmHg or pulse oximetry oxygen saturation value less than 90% on room air should be regarded as additional evidence that patient exacerbation is severe. Therefore, although ABG is not recommended as routine during initial evaluation of patient with acute exacerbation of asthma, it should be done for evaluation of severe cases. Understanding the expected change of partial pressure of arterial CO2 during asthma exacerbation is important for recognition of rapid deteriorating course. With modest airway obstruction, the patient's mild dyspnea stimulate increasing minute ventilation that meets or exceeds the level required to maintain normal alveolar ventilation. Thus, patients with modest obstruction have normal and slightly below normal PCO. Airway obstruction worse, dyspnea become more severe and central nervous system drive to increase minute ventilation become intense. Typically, increase in minute ventilation exceeds the level required to maintain constant alveolar ventilation. Consequently, patients with moderate to severe obstruction have lower than normal PaCO2 and acute respiratory alkalosis. As airway obstruction become more severe and prolonged, high minute ventilation can no longer be maintained by respiratory musculature and alveolar ventilation decreases. As a result, the PaCO2 rises towards normal and then continues to climb, resulting in hypercapnia and respiratory acidosis. Thus, normal or high PCO2 during severe exacerbation of asthma is potentially ominous finding and often signifying the impending need for mechanical ventilation. Any coexisting condition or medication that weakens the respiratory muscle function or depress respiratory drive should be expected to accelerate the onset of hypercapnic ventilatory failure during acute exacerbation of asthma. Other lab studies for acute exacerbation of asthma, routine chest radiograph reveal few abnormalities other than hyperinflation. However, although not recommended for routine assessment for severe exacerbation, chest radiography can be helpful when there is clinical suspicion of other cause of dyspnea and wheezing or complication of severe airway obstruction. Chest radiograph should be examined for evidence of enlarged cardiac silhouette, upper lung zone redistribution of blood flow, pleural effusions, and alveolar and interstitial infiltrate. Because of any of these findings suggest the diagnosis other than or in addition to acute asthma. In addition, chest radiography allows the early recognition of common complication of severe airway obstruction, including pneumothorax, pneumomediastinum, and atelectasis. Also, lung infiltrate on chest radiograph can be compatible with diagnosis of asthma complicated by mucoid impaction and or complications associated with them. Allergic bronchopulmonary aspergillosis and eosinophilic granulomatosis with polyangiitis. Among the elderly, for patients with severe hypoxemia or for individuals with suspected cardiac ischemia or arrhythmia, an ECG should be performed. Sinus tachycardia is common during acute exacerbation of asthma, but less common and transient findings include right axis deviation, right ventricular hypertrophy and strain, P. pulmonale, ST T wave abnormality, right bundle branch block, and ventricular ectopic beat. Now, regarding therapeutic agent, treatment of severe acute exacerbation of asthma, pharmacological agents are anti-inflammatory agents like systemic corticosteroid, bronchodilators like inhaled short-acting beta-2 adrenergic agonist, inhaled short-acting cholinergic agonist, intravenous MgSO4, oral or intravenous methylxanthine, systemic beta adrenergic agonist, and general anesthesia. Then supportive measures are frequent reassessment, supplemental oxygen, fluid management, invasive mechanical ventilation if needed, helium oxygen mixture to drive nebulizer, lavage by bronchoscopy. Then on education, avoidance of asthma trigger, medication use, access to medical follow-up, and home monitoring of airway obstruction. Because the dominant cause of airway obstruction during asthma exacerbation, a result of airway inflation, the cornerstone of treatment is anti-inflammatory therapy with systemic corticosteroid administered within 1 hour of presentation. But corticosteroids take at least 4 to 6 hours to begin and to have beneficial effect. Many of inflammatory causes of airway obstruction may take days to resolve. And the medical challenge is to support patient until the inflammatory process have responded to corticosteroids. Beta adrenergic agonists relieve the airway obstruction due to airway smooth muscle contraction, and this is important therapeutic maneuver during initial treatment. Of the available bronchodilator, beta 2 adrenergic agonists are the most effective and rapidly acting, therefore most useful during the critical time before onset of corticosteroid action. Other measures that support the patient until inflammatory process in the airway have resolved include supplemental oxygen, judicious fluid administration, and when indicated, mechanical ventilation. Regarding beta 2 adrenergic agonists bind to beta 2 adrenergic receptor on airway smooth muscle and causes the relaxation of the muscle. Although the primary cellular target of beta 2 adrenergic agonist is airway smooth muscle, the other cell type in the airway also express the beta 2 adrenergic receptor that may regulate mediator release by mast cell, epithelial cell, and there are three general classes of the beta 2 adrenergic agonist. First, short-acting beta 2 adrenergic agonists have bronchodilatory effect that lasts for 3 to 5 days. They include epinephrine, isoproterenol, terbutaline, metoprolol, and albuterol. These short-acting agents are rapidly acting with onset of action less than 5 minutes and are mainstay of bronchodilator therapy for acute asthma, especially albuterol. A systemic review and meta-analysis concluded that levoalbuterol, a single isomer preparation of albuterol, was not superior in efficacy or safety when compared to racemic albuterol. Second, there are long-acting beta-2 adrenergic agonists that have either slowly and rapidly acting bronchodilator effect lasting for at least 12 hours. Third, there are ultra-short acting beta-2 adrenergic that have half-life suitable for once daily dose. Neither long-acting beta agonist or ultra-long-acting beta agonist are currently recommended for emergency department or hospital treatment of severe acute asthma exacerbation. The major side effect of beta-2 adrenergic agonists during treatment of severe asthma exacerbation are tremor, cardiac stimulation, hypokalemia, and hyperlipidemia. These side effects are potentially serious, especially in elder who frequently have underlying cardiac disease. Cardiac toxicity can be minimized by using agonists with high beta-2 adrenergic receptors selectively and by avoiding systemic administration of beta-2 adrenergic agonists and by maintaining adequate oxygenation. Beta-2 adrenergic agonists can be administered to patients by inhalation, subcutaneous, and intravenous route. Numerous studies have shown that bronchodilatory effect of inhaled beta-2 agonists are rapid in onset and equal to the effect achieved by systemic delivery. Because the inhaled route allows the administration of comparatively small dose directly to the airway with minimum systemic toxicity, this route is almost always preferable to systemic delivery. Several options exist for delivery of inhaled beta-2 adrenergic agonist, that is small volume nebulizer is widely used. However, studies have shown that metered-dose inhaler equipped with spacer devices are effective at small volume nebulizer in the treatment of acute asthma, although some patients may have difficulty coordinating metered-dose inhaler use, especially during acute exacerbation with severe respiratory distress. Frequent multiple inhalation of medication may allow for progressively deeper penetration of drug into peripheral airways, In fact, continuous administration by nebulizer may be more effective for severely obstructed patients. For administration of inhaled albuterol in the treatment of severe exacerbation of asthma, National Institute of Health guideline recommended treatment with MDI, that is 90 microgram per puff, 4 to 8 puff every 20 minutes up to 4 hours, and then every 1 to 4 hours as needed, or nebulizer treatment, either intermittent, that is 2.5 to 5 mg every 20 minutes for 3 doses, and then 1 to 4 hours as needed, and then continuous, that is 10 to 15 mg per hour. Because of its low density than the oxygen, helium oxygen powered nebulizer treatment have theoretically potential to improve penetration of aerosol into the lung. However, systemic review with meta-analysis comparing heliox versus air oxygen driven nebulization found no support for helium powdered nebulization in routine care of acute exacerbation of asthma. However, data have been mixed and guidelines do suggest that heliox powder delivery method to be considered to potentially avoid intubation for patients with severe life-threatening exacerbation. Theoretically, systemic administration of beta-adrenergic agonist could deliver drug via bloodstream to obstructed airways that are poorly accessible to inhaled aerosol. However, this theoretically advantage has not been supported by most of the studies. Subcutaneous epinephrine, that is 0.3 ml of 1 to 1000 solution every 20 minutes for 3 doses, was the traditional therapy for acute asthma in emergency department, but it is not more effective than aerosol delivery of beta 2 adrenergic agonist. A major concern for use of subcutaneous epinephrine to adult has been cardiac toxicity. More selective beta-2 adrenergic agonists such as terbutaline are available for subcutaneous use, but cardiac toxicity among elderly is still significant concern even with these more selective agents. Formerly, intravenous isoproterenol, that is 0.05 to 1.5 microgram per kg per minute, was used to treat severe exacerbation of asthma. However, intravenous delivery of beta-2 adrenergic agonist is no longer recommended for routine treatment of even severe exacerbation of asthma. No convincing evidence has shown intravenous administration to be superior to inhaled delivery of beta-2 adrenergic agonist. Both the lack of enhanced efficacy and potential cardiac toxicity of intravenous beta-2 adrenergic agonist have led most authority to reserve intravenous delivery for those rare adult patients closely monitored and who continue to deteriorate on mechanical ventilation despite maximal routine therapy with inhaled beta-2 adrenergic agonist. Intravenous beta-2 adrenergic agonists are not recommended in the guidelines. Regarding cholinergic agonist, for asthma with muscarinic cholinergic agonist, that is atropine, ipratropium, and tiotropium, are less effective and more slowly acting bronchodilator than beta-2 adrenergic agonist. In general, these agents should not be used as sole bronchodilator therapy for acute asthma. Exceptions may be bronchospasm induced by acetylcholinesterase inhibitor and beta-2 adrenergic antagonist and patients with the severe cardiac disease who are unable to tolerate beta-2 adrenergic agonist. However, inhaled cholinergic antagonists do have low incidence of side effect and are recommended adjunct to beta-2 adrenergic agonist for initial and emergency department treatment of severe exacerbation of asthma and have been shown to decrease the risk of hospitalization. The long-acting anticholinergic tiotropium has a role in treating outpatient with difficult to control asthma, but it does not have an established role for treating hospitalized patients with acute exacerbation of asthma. Regarding methylxanthine, because literature does not demonstrate a benefit to adding methylxanthine to beta-2 adrenergic agonist in acute setting because they increase toxicity, methylxanthine are not recommended for treatment of asthma exacerbation. For the very rare critically ill patient whose condition is acutely deteriorating despite maximum recommended therapy with bronchodilator, corticosteroid, and other agents, the use of methylxanthine might be considered by some physicians, although data are not supported. Intravenous infusion always must be carefully monitored and dosed with attention to condition that decreases methylxanthine clearance, especially congestive heart failure, cirrhosis, and the use of drugs such as cimetidine, ranitidine, allopurinol, oral contraceptive, erythromycin, ciprofloxacin, or norfloxacin. Serum theophylline level should guide the adjustment so the infusion rate with 10 to 15 microgram per ml being therapeutic. Serum concentration greater than 20 microgram per ml are toxic. Regarding corticosteroid, numerous studies have documented the safety and effectiveness of short course of corticosteroid for treatment of acute exacerbation of asthma. Their beneficial effects are attributed to their many potent anti-inflammatory effects on multiple cell types. Systemic corticosteroids are principal therapy for acute exacerbation of asthma. Prednisone, and methylprednisolone are the preferred agent. Compared to betamethasone, dexamethasone, neither prednisolone nor methylprednisolone contain metabisulfite and both have shorter half-life. Although hydrocortisone has shortest half-life, it has a greater mineralocorticoid effect and may cause idiosyncratic bronchospasm in some aspirin-sensitive individuals. The optimal use of corticosteroid administration during the treatment of acute asthma is not well established by studies. For initial treatment of acute exacerbation of asthma, studies suggest that oral administration of corticosteroid is as effective as intravenous therapy. Therefore, oral route is preferred unless there is possibility of impaired GI tract transit time or absorption. Inhaled corticosteroids do not have well-established role for treatment of acute exacerbation of asthma. In emergency departments, some data suggest that inhaled high-dose corticosteroids do decrease hospitalization rate for patients not additionally received systemic corticosteroids. However, because systemic corticosteroids are recommended for patients with acute exacerbation within an hour of presentation, it is not established that inhaled corticosteroids offer any additional benefit and they are not recommended in the guidelines. Oxygen supplemental oxygen therapy should be initial intervention in emergency department. Because ventilation perfusion mismatch is the dominant cause of hypoxemia and asthma, PaO2 usually increase readily in response to low level of supplemental oxygen therapy. Studies have shown that titrated low flow oxygen therapy to achieve oxygen saturation of 93 to 95% is associated with better outcome than the routine use of untitrated high flow 100% oxygen therapy. GINA guidelines recommended titrating oxygen to achieve oxygen saturation of 93 to 95%, but not greater than 96%. And NIH guideline recommended titrating oxygen saturation to more than 90%. In addition to mitigating cardiac and neurological complication of severe hypoxemia, low flow supplemental oxygen minimizes potential episode of hypoxemia due to acute administration of beta 2 adrenergic agonist, decreases elevated pulmonary vascular pressure due to hypoxic vasoconstriction, decreases bronchospasm due to hypoxia, and improves oxygen delivery to respiratory muscle. Other agents are intravenous magnesium sulfate, that is 2 gram of magnesium sulfate in 50 ml saline during 20 minutes has bronchodilator property. Magnesium sulfate is not recommended for routine use of treatment of asthma exacerbation, but it may be considered for treatment of severe asthma exacerbation. As evidence suggests, it may prevent hospital admission when used in those patients who have not responded to beta adrenergic agonist and corticosteroid therapy. Although the data are mixed, inhaled rather than intravenous, magnesium sulfate may have role in treatment of acute asthma. That is, for severe asthma exacerbation, albuterol nebulized diluted in magnesium sulfate solution may be more effective bronchodilator than the albuterol nebulized in normal sulfate. Because of its low gas density, some improvement in airway resistance and gas exchange may be achieved by delivering mixture of helium and oxygen gases to patients with airway obstruction, at least theoretically. However, clinical studies have not proven and guidelines do not recommend the routine use of heliox as substitute for standard supplemental oxygen in treatment of asthma. Guidelines do not recommend the considering heliox-driven albuterol nebulization to possibly avoid intubation in patients with life-threatening exacerbation unresponsive to initial therapy. Some therapeutic agents are used for treatment of stable asthma, have no established role in the treatment of severe exacerbation of asthma among hospitalized patients. These include aerosolized corticosteroid, sodium cromolyn, as well as oral beta 2 adrenergic agonists that may cause significant systemic toxicity. Although there is yet no established role for the use of leukotriene antagonists for treatment of asthma exacerbation, some evidence suggests the possible role and need for the further study. Mucus is important cause of airway obstruction during acute exacerbation of asthma, but the routine use of mucolytes such as acetylcholine, potassium iodate, and the human recombinant deoxyribonuclease has not been shown to be effective for treating severe exacerbation of asthma, and at least one of these agents, that is acetylcholine, may worsen cough and bronchospasm. Fluid therapy should be used conservatively unless significant dehydration is present. Bacterial infection appear to play at most a minor role in the precipitation of severe asthma exacerbation. For this reason, antibiotics are not routinely administered unless an active bacterial infection process, particularly pneumonia, bacterial sinusitis, is suspected. However, infections due to chlamydia pneumoniae might play a role in pathogenesis of asthma exacerbation for some patients. Unless a patient is mechanically ventilated, sedation has no role in treatment of severe exacerbation of asthma. Opioid and other sedating medication may depress the respiratory central drive to breathe that is critical for maintaining adequate alveolar ventilation. Theoretically, some opioid may also cause mast cell degranulation and worsen bronchospasm. Thank you, guys.